results. And we studied the genetic polymorphisms in candidate genes for methotrexate, and we studied the NUT15 and TPMT genetic polymorphisms which predispose a child to get rid of the 6-mercaptopurine. And again, we are using it in our daily practice. This is a child happy to finish the last day of chemo. We go to the other modality of treatment, which is radiotherapy, and we use the radiotherapy facility at the American University of Beirut. It is very high-tech. It has everything that we need for the patients of the Children's Cancer Center of Lebanon. Radiation therapy kills cancer cells and keeps them from growing and multiplying, and we surely use this facility. And this is to show you the CT simulator where a child goes and mark on his skin, and the amount or the area that needs to be irradiated gets demarcated very nicely and very precisely, so that radiation is given exactly in the same place that we need it to be given. And this is the linear accelerator also at the American University of Beirut. There is a high-tech linear accelerator which delivers radiotherapy exactly to the area we need to give it to, and it avoids the surrounding tissue. Now we go to the third modality of treatment, which is surgery. And being in a middle-income country, it is not strange that we see such children with very big bellies coming. They do not come, sometimes, most of the time they don't come early, so we end up having a very big tumor, and the surgeon, our surgeon, needs to remove such a big tumor. But this is very important because getting rid of this tumor increases the chances of survival. And one thing I would like to mention, and we owe much to our orthopedic surgeons who have introduced limb salvage surgery to our center. And many years before the center was opened, patients used to get amputated if they had a bone tumor. With the help of our orthopedic surgeons, now nobody gets out or is treated with amputation, or very few. And what they do is a special technique where they remove the tumor and they put a prosthesis. And this prosthesis is functional. Even sometimes the prosthesis can be elongated. So you see this piece of metal. Sometimes when the child grows, because we're dealing with children who grow 4 or 5 centimeters sometimes per year, so you need to elongate the prosthesis in order for the legs to stay the same length. And again, this prosthesis can be elongated. You take them, put it in an electromagnetic field. It has a coil that elongates. And limb salvage surgery has been very instrumental for treatment results and outcome at the Children's Cancer Center of Lebanon. And again, if you visit the center, you will see nobody with an amputated leg, and you see many walking normally, and they have this prosthesis inside their leg or arm. Again, thanks to the orthopedic surgery team. Over the past 15 years, more than 100 limb salvage surgeries have been done by the orthopedic surgery team, and we are a referral center for the whole region, and many places would like to use the expertise of our orthopedic surgery team, and they send their patients to be operated at the Children's Cancer Center of Lebanon. I have to mention something very important, which is multidisciplinary approach. If we're going to go to surgery, radiation, or chemotherapy, it's always not a one-person decision. It is a multidisciplinary approach. We sit together at tumor boards or outside tumor boards, the surgeon, the pediatric oncologist, the pathologist, everybody, and we discuss the case, the patient, and it is a unanimous decision to any treatment that will affect the patient, and no patient gets treated by one person or one doctor's opinion. As you know, treating cancer is not without side effects. Sometimes a patient after treatment for cancer has some psychological problems. The cancer might recur. They might have a problem with fertility and reproduction. They might have one of the organs affected, whether the heart, whether the endocrine, and they might have a problem with growth and development. So what is new in the horizon, and the new things coming, and what we will be hearing more and more about in the future is smart targeted therapy. They are medicines that target the tumor cell and target the normal cell much, much less, nearly very little or no affection of the normal cell. And actually it is called smart because it's smart. You don't want to kill normal and abnormal cells and then wait for the normal cells to come up again. If you have a technique which kills only the normal cells, only the abnormal cells, and leave the normal cells aside. So immunotherapy uses a basic principle. It makes our body, uses things in our body to fight cancer. Instead of getting a chemotherapeutic agent from the outside, putting it into the body, killing the normal and the abnormal cells, this immunotherapy, the future, the new technique, kills only or mostly the cancer cells, and it uses our body mechanisms to fight cancer cell. And the T cell is one of the cells in the body, in our blood, and the T cell is supposed to be the policeman to kill the cancer cells. However, the cancer cells are tricky, and sometimes they do not let the T cell recognize them. So immunotherapy comes in and makes the cancer cell visible to the T cell. This is one modality of immunotherapy, so that our T cell, the T cell in our blood and in our body, can recognize the tumor cell and kill it. Again, I would like to finish by something we are all proud of. The survival rates at the Children's Cancer Center of Lebanon, 98% for Hodgkin's lymphoma, 92% for acute lymphoblastic leukemia, and very good survival rates. Excuse me for putting this slide twice, but actually I'm proud of it. Everybody in the Children's Cancer Center is proud of these results. Thank you.
شكراً دكتورة موقت. بعد ما شفنا عرض سريري للكانسر وعرض لأبرز العلاجات، بيبقى جانب كتير مهم يلي هو أحدث الاكتشافات والأبحاث المتعلقة بسرطان الأطفال. وين صارت اليوم هالاكتشافات وهالأبحاث الجديدة؟ منشوفها مع نائبة المدير الطبي لمركز سرطان الأطفال دكتورة ريا صاب.
Thank you very much. So what I will try to do in the next 10 minutes or so is to introduce you to the concept of cancer research, what it is, why is it important, and to touch upon the major areas that are currently undergoing very exciting activities in cancer research and will change the way that we will be treating patients with pediatric cancer in the very near future. So just the basics first. You all know that research in general, just as the name signifies, it is investigating a particular question and trying to find an answer to identify facts and test them to be able to prove a hypothesis or a theory. And medical research is research that is done to support the development of medical treatments, to better understand how a disease happens, to better understand the way to treat it, and why, and the side effects that medications cause and how to prevent them. Now, it is very important to realize that progress in the treatment of pediatric cancer started really not too long ago. And in the morning session, Rick Shidiak touched on that when he mentioned that it's really over the past 50 years that we have made progress in the treatment of cancer. If you think about that, you know, and for the young people, for the young students in the room, when your parents were kids, cancer in pediatrics was not curable. So it's really less than a lifetime ago that we started to make those advances. Actually, it was in the 1950s that the first children started to be treated with chemotherapy. And at that time, people thought that the doctors that were using chemotherapy were crazy, that they were hurting those children by giving them toxins. And then after that, the first cures in pediatric leukemia started to appear, and people became more interested in trying these therapeutic agents. And these were the first researchers that actually had a novel idea and decided to try to save those kids. Prior to that, the diagnosis of cancer was a death sentence. So after that, after the first few kids started to get better with single-agent chemotherapy, that's when clinical research, clinical studies in children with cancer started to be accepted and to happen in the Western world primarily. And it was not until the 1970s that the first combination chemo studies started. So we started using more than one medicine to treat pediatric cancer. And this is when we started to see cures. In the 1980s and the 1990s, researchers started thinking of how can we adapt the treatment. We noticed that we are having too many side effects, just like Dr. Mouawad said. Some kids have more side effects than others. Some kids are better cured than others. So do we really need to give all this chemotherapy to the same patients? So that's when clinical research started to try to identify which kids, which children need less treatment to be cured and which children need more intensive treatment to be cured. And this is a concept that we call now risk stratification, and we apply it for all kids to be able to get the 98% cure rates in lymphoma, for example, and the 90% cure rates in leukemia, while decreasing the side effects. At the same time, in the 80s and the 90s, there was a lot of work to understand the biology of the tumors. What makes this normal cell start dividing and invading tissue and going to distant places? What causes it to become cancer? And this is what is called basic research. And in the 1980s and the mid-1980s was the first time that we, the scientific community, discovered the drivers of cancer, which are oncogenes and tumor suppressors. And this has really revolutionized our understanding of what cancer is and how we can develop new medicines to battle it. In the 2000s, there was further understanding of tumor biology, and this was the first time that we started to identify medicines that can target a particular abnormality in the genes in order to treat cancer, to get medications that specifically kill the cancer cell and do not kill normal tissues around it. And this has resulted in revolutionary therapies in things like some types of leukemias. And then over the past decade, there has been a lot of progress, specifically in the tumor genomics. And the reason, cancer research, the way that things progress in cancer research is that we build on the discoveries of others. And at the same time, technology is advancing and it is becoming cheaper. So for example, over the past 10 years, we have been able, since the human genome was able to be sequenced, now we are able to study the whole genome of the tumor cell at a much less cost than we did 10 years ago. And this has really created an explosion in the information that we have now about the types of abnormalities in childhood tumor cells. And this has also opened the area for new treatments that are coming up. At the same time, there has been a lot of advances in the field of immunotherapy, as Dr. Mouawad alluded to, with harnessing the patient's immune response to help kill the tumor cells. This slide just shows you the progress that we've made. Again, in the 1950s, the cure rate was less than 10%. Now, overall, for all childhood cancers, it's around 80%. And research is really how we made those advances, each small piece of research building upon the previous one. And every year somebody comes up and asks me, well, what have you guys discovered over the past year in research? And the important thing about cancer research is that most of the time, there are some times that we make huge steps, like recent trials in immunotherapy. However, most of the time, we make small steps that build upon each other so that we can move from a cure rate of 20% to a cure rate of 80% over 50 years. So we've made a huge progress. However, we need to continue to push the cancer research forward to improve care furthermore. An 80% cure rate means that 1 in 5 children treated for cancer still dies, and that's one child too many. In addition, the current treatments that we use, out of every 4 children treated, 3 will have lifelong problems in their heart, in their kidneys, with the reproductive system, etc., that they will have to live with for the rest of their life. So we really need to do better. We need better medicines. We need to better understand the biology of the cancer to find the right medicine for each tumor type, and to give less treatment to kids who don't need intensive therapy and more treatment to kids who have tougher to treat cancers. So a few words on the recent advances in pediatric oncology. Probably one of the biggest advances over the past 6 years or so has been understanding the genomics of childhood cancer. Dr. Tarek told you that about 10% of pediatric cancers are heritable and the others just happen by chance. Over the past 6 years, there has been a lot of understanding of the genomics, the genes of several subtypes of pediatric cancers. And there has been more and more insight into an increasing number of predisposing genes that have been found. Last week, I was just at the major cancer research meeting in the USA, and it is thought that it might be up to 25% of childhood cancers where there might be predisposing genes in the population, but the predisposition is very small. So the 10% are the ones that we can recognize and we can counsel the family about. But there are probably many more that we don't understand very well. And this 10% number that we discuss now, in 10 years might become much higher as we know more about the cancer and can counsel families. And this is why it's very important to continue to do research in genomics of cancer to be able to counsel treatment patients better, and at the same time to be able to identify better ways to treat those tumors. Combination chemotherapy, again, over the past 10 years, there has been a lot of improvement in the risk stratification that I mentioned, giving more chemo to some patients and giving less chemo to others. The same tumor, leukemia or brain tumor, depending on multiple characteristics, biologic characteristics, some will need higher treatment, some will need lower treatment. Immunotherapy, this is the very hot topic because for the first time in very difficult to treat tumors, we are seeing improvement in the outcome because of these novel immunotherapy. These come at a very high cost, and again, this is a challenge for healthcare systems. And finally, understanding the way that the patient's system metabolizes the drugs that we give them. Why some drugs work better in some kids, why some drugs have more side effects than another kid. There's a lot of work being done in that field as well. So I will end with just sort of an overview of what research is being done at the Children's Cancer Center at the AUBMC, and this is research that is done by all the doctors at the Cancer Center, and it is all geared towards improving outcome of childhood cancer. It includes clinical research, clinical outreach, tumor banking, and basic research. So to start with basic research, this is the lab-based research. We have a large group of PhDs, graduates, students who are studying two primary projects. First is how does a normal cell become a cancer cell, and better understanding of this process will help us target it better and reverse the process. And second is studying new ways to treat one very aggressive muscle tumor in children called rhabdomyosarcoma. We have clinical and translational research, understanding why some children have more side effects than others, and this is some of the work that Dr. Mouawad showed that she has been leading. Studying the tumor gene profile to personalize the treatment to each tumor profile. And we are part of a big consortium where there are more than 21 centers, all of them in North America. We're the only center outside North America that is part of this consortium. And we have a study where we are trying to understand the genes that are abnormal in a particular tumor and try to match it with the correct drug. Clinical research, we have an open study on better treatment of acute